Tasha was just saying, you can have definitely different breath sounds in different lobes. You can have wheezes and crackles in one, even just the right lobe itself. You can have issues going on in just one particular lobe and not the entire lung itself. So you could have hoarse crackles in that right lower lobe and then have fine wheezes up here in the right upper lobe. So you can have different issues going on, and you can have pneumonia in the right upper lobe, but in these lower lobes not have anything going on. And you think, well, gravity, you would think it would just all fall down, but look how things are branching out. So not necessarily. So we could have this lung or lobe infected, but that doesn't necessarily mean all the other lobes will be infected.
And then the other one can be completely fine.
Yeah, yeah. Okay, so number 10 is looking at the bronchi themselves. So that's the big branches, and we're on page 340. So I do want you, well, so we'll look at the primary bronchi. Yeah, you should have this one for labeling. Primary bronchi, that's just these two main branches. I like the picture in your book better than I do this one, and I'll show you why. Because it shows you the difference in the primary bronchi. So what I'm meaning by the difference is, if you're looking at this, which one of these primary branches, which one is more vertical and just like straight down almost, right? The right one. So that being said, and you thinking about that goes straight down, what do you think the recovery position is? So if someone just had a seizure, or we did CPR and got them back, they have a pulse and respiration, we put them in the recovery position, and which position is that? Left or right side? We roll them. Say again? Left side. So if I roll them over onto this lung, onto the left side, why would I not want to roll them onto this one?
Because it's all going to go down there?
Yeah, yeah. So if you have a buddy that's vomiting for whatever reason, you don't want to roll them on their right side, because then they can actually aspirate, and it has a better chance of going straight down into the lungs and blocking airways than it would in this one, because this is more horizontal. So this one is straight down.
Never heard of that. Roll them on the left side.
Okay. If anything, just roll them on their side, period. But
So just put down their roll on left side?
that's just for your info. But you do want to know which one is more vertical.
What's in front of
You're right.
Primary. She put
Primary.
1 degree.
Primary bronchi. So primary bronchi, the biggest branch. Then we get into, so those are the primary bronchi. Then you get into, and your book colors them yellow, your secondary. Secondary bronchi. So it's just a little bit bigger branches. And then we get into your tertiary bronchi. So in your book, it's the orange. And then you get all the way down to your bronchioles. Remember, we talked about arterioles. That's the baby arteries. So these are the baby bronchioles. Bronchioles. And we'll look at those at the next picture down here in just a minute. So you do have to memorize those. all the way back up to 11. Looking at that epiglottis. You can find it on page 339. And we've already talked about it quite a bit already. So it's the flap that closes over the glottis. Because it's just above it. It's the epiglottis. So it's just right upon it, the epiglottis. Right upon the glottis. It flaps over and closes over the glottis when swallowing. So it protects our airway. This we're just gonna call the pharynx, but we'll branch off. So if you're looking, so here's the nasopharynx. Pharynx we think of just our throat. So the nasopharynx is just behind the nasal cavity. So this one is just behind the oral cavity. So what would we call it? Yeah, the oropharynx. And then the one that's just behind the larynx, what would you call it?
The
Yep, laryngeal pharynx, yep. So the throat, the pharynx, is broken up into 3 areas: nasal, oral, and laryngeal pharynx. The oral and the laryngeal, those are the only 2 that have passage of food and air. So they have air and food that both go through those. Whereas the nasopharynx, you shouldn't have food or water or anything go up through it. Because if you do, like when you're, when you have milk coming out your nose, then that's when it's gone up through the nasopharynx. And you know how that feels, because it shouldn't be there. So the pharynx, including the oral and the laryngeal, those 2 share food and air. These 2 here. Not the naso. 13 is just pointing down here to the opening, the glottis itself. The opening between the vocal cords. Opening into the trachea. Get finished with these here and then we'll take a break. 14 is pointing to the vocal cords we talked about. So they vibrate with air to produce sound. They're pointing to the bronchioles on 14.
You mean 15?
On 15, yes. So the smallest airways. Bleeding into those alveoli.
Sixteen's just left lung, right?
16 is the left lung. So the left lung has how many lobes?
2.
2 lobes.
LUL and LLL.
So you can label them again. You can have them as superior left lung lobe and inferior left lobe, or you can label them as left upper lobe and left lower lobe. So this can be the superior again or inferior, whichever you feel comfortable doing. Now this one, this lobe here, it is kind of pushed over. We said it's a little more narrow than the right one. So if you're looking on page 342, you can see the lungs. You can see that superior, inferior. So this one, why is it a little more narrow and pushed over?
Because the heart.
Yeah, because of the heart sitting right there. Sitting right there in the middle.
How does the diaphragm not push on the heart?
It does help push on the heart some, but it doesn't cause any issues. Remember, we've got a big pericardial sac, it's enclosed in, so it's freely moving inside there, that pericardial sac, and then we've got the lining of that pride or visceral flora on these lungs that are helping push on it as well. So they just slide across each other. So we have a hilum. It's kind of the, if you took all this stuff out in the middle here, and you took that lung, you would see that's kind of concaved on the inside. See it? Yeah, right here. Here's a good picture. So it's kind of concaved on the inside, and that's where we have branching of not only the primary bronchi going into the lungs, but you also have arteries coming in, you have veins going out, and then you have the heart sitting there nestled in between the two lungs. So those hilums are kind of notches that are made out because of the things that are going in and out. Apex of the lung, I have you label it in your labeling, and it's because it's important, because when we're looking at x-rays, they'll measure how high the apex is above this clavicle, because if these lungs are overinflated, then they may be, several centimeters above the clavicle.
So the apex is like the tip of the lung.
Yes, the top of the lung. So it should normally be about a half an inch or 1.3 centimeters above the very first rib that's coming through on an x-ray. So then they'll measure, and if it's, say, 2 centimeters above it, then that lung is overinflated. And it may help with the diagnosis of things like emphysema. So apexes are a big thing to know, or, you may not see the apex. It may be further down, and it's because we may have punctured and caused collapse of the top part of those lungs, whether it's left or right, especially when we're placing, when the physician is placing a subclavian line. So it's a central line placed up here in the chest area. Sometimes they can accidentally puncture the membranes around the lung and cause that top part of the lung to collapse. In the base of the lungs.
Will there be a way for us to, before the test, know how many labeling there is, so we know that we added enough to study?
You just need to know everything that's on the page. Everything that's on every single one of those pages I gave you is
You don't
labeled.
have to add anything to them?
Look in your book and see, like page 342 is labeling. So everything that's listed on that page is labeling. Let's look lastly at the
Diaphragm.
diaphragm, and then we'll take a break. So on page 342, you can see the diaphragm. The way it's looking right there, where it's kind of bubbled up, that's actually relaxed. We normally think of muscles being flattened and that be relaxed, but the diaphragm is a little opposite of that. When it's resting up, it's when it is relaxed. So when it starts to contract, when it contracts, it pulls down and it will flatten. So usually you're confused about how the diaphragm sits when it contracts and when it relaxes. So contraction would make it go flat and pull down. So then it's helping to inflate or fill those lungs. And then when it starts to relax, it starts to go back up and pushes against those bases of those lungs. So you can see how, again, when it's relaxing, the air's being pushed out passively because this big muscle is starting to go back up and push on those lungs. And at the same time, remember, those ribs are starting to collapse down and compress on those lungs. So everything's starting to squish on the lungs and push everything back out passively. So the diaphragm, when it's contracted, it's flat. When it's relaxed, it's dome-shaped. So contracting is work, relaxing is passive. So when it's contracting, it flattens and we are inhaling. When it's relaxed, it's going into its dome shape and we're exhaling. Before we move on, let me finish up these few pages. We'll come back to page 341. That's what we're going to talk about in just a minute after break. On page 344, I've already talked a little bit about the primary muscles, so your intercostals and the diaphragm. But I want to talk about your accessory muscles. So the sternocleidomastoid muscle is attached to the sternum, as well as those scalens that are attached to the clavicle and the ribs. And then these abdominal muscles and the pectoris muscles, those are all considered accessory muscles. Those accessory muscles, you notice them if you're exercising and you're really huffing and puffing. So you notice that you're heaving and your chest is going up and down, and you see all the muscles in your neck, and you may even see your pectoris muscles contracting. And when you're running and you're breathing so hard, you can feel your stomach even contracting. So those, you've noticed accessory muscles normally in a normal day-to-day if you're exercising. Now, when we see it abnormal is when we have people with respiratory diseases or disorders, like emphysema is a classic one. And that's because they lose elasticity. So from smoking over years and years and years, causing inflammation in these sacs start to burst. And so you see they're individual little bitty sacs, all individual sacs. Well, they start to burst, and then they create like one bigger sac. Well, it's harder to contract down that one big sac unless they were unlike our normal little tiny sacs. So when they start to converge together and have larger openings, then these smooth muscles that are around all of those alveolar sacs cannot contract them down and squeeze out the air. So the problem with your emphysema patients is it's not getting air in, and that's what it appears, because when you see them get up and walk across the room, they're like really huffing and puffing and trying to get, seems like, air in, but it's not. If you take an x-ray of their lungs, they're really big and white. They're like really long, really wide, and really whitened out, and that's because they're overinflated. They can't get air out because those sacs will no longer squeeze down. So what happens over years of that happening, then we start to call upon accessory muscles to push and try to get that air out. So you'll notice on these patients, one, they become really skinny. So later stages of emphysema, they're really skinny. One, because they can't, think about when you're sick and you can't eat and breathe at the same time. You're all stuffy and you're like, I can't even breathe. I gotta stop and breathe. Well, they can't breathe and eat. So they don't eat as much. They'll eat really fast. And then they start to get what's called a barreled chest. So they build up these accessory muscles. They get bigger pectoral muscles, and they get a bigger abdomen. And it's all the purpose of manually pushing down on those lungs to expel air. So that's why they get this barreled chest. The barreled chest is actually, we can measure it and assess it, and we say it's a 2-to-2 ratio, because normal chest is a 2, that means the width of it is twice as wide as we are this way when you're thinking chest. So this is 1-to-2. Theirs is 2-to-2. Their chest is as wide as it is this way wide, because of those accessory muscles they've built up and the overinflation of the lungs.
That's on 348.
So accessory, it's on page what?
348, a normal and barrel chest of emphysema.
348. Yes, there you go. On the bottom of 348, talking about a barrel chest. And they get into what's called a tripod position when they're out walking around. So you'll see these little old people kind of grab a hold of something and they're doing this. And what they're doing is that, again, helps to push down on that thoracic cage and push out the air. All right, that's, and then make sure you know the neural control for breathing on page 348. We've talked about it a million times. We've talked about how important the medulla is, but we haven't talked a lot about the pons. So the medulla is the main one, it's the one that decides whether we breathe or not, but the pons assist. It kind of fine tunes our breathing.
On 348?